I think the earliest experience that I can remember is the death of my grandmother. I was about 10 or 11 years old. She had cancer. This was a time in rural India where there wasn't much disclosed about the diagnosis or prognosis. I remember my grandmother being admitted to hospital, very jaundiced, seemingly unaware of what was ailing her and how much life she may have left. And a standout memory for me during that time is her youngest son was getting married. And so the family stole her out of the hospital to attend the wedding because I suppose everybody knew that she didn't have long to live and the wedding had been brought forward as a result. And the doctors and nurses were so mad, I guess rightly so, that a patient had been stolen out of hospital to attend this wedding and then brought back to the hospital. And then, unfortunately, my parents and I had to leave India to go to the UK. And the next thing we heard that my grandmother had died. I've written about this before, sort of thinking that the series of events that happened could have happened differently. We never got back to see our grandmother because it was very difficult to travel during that time. It was also very expensive and not expected, I suppose. Death is commonly spoken about in India, and it's sort of a cycle of life. And it would be quite common. In fact, I was just visiting India recently with my children. I have an elderly uncle who has just turned 89. And it would be very common to sort of sit at breakfast where he would say, well, I don't know how much longer I have to live or when I die. And no one stops, everybody just keeps eating and the conversation continues. No one rushes in to say, oh, that won't happen or don't speak like that, which I think is normalizing to everyone that just as you are born, you die and you try to enjoy the period in between. I think in general, we don't speak about death here. We know we should, but we are not good at discussing death and dying. We live in a very transactional and a modern society which is full of glitter and glamour, and there is not much space on a regular basis for reflections on one's mortality. I've always seen my role in medicine as public service. And I think such an important element of being a doctor is obviously to treat the individual patient with care and compassion, bringing all your knowledge to the treatment of that patient, but also being aware of the broader societal issues that we deal with. And when I look at my 20 years or more in oncology, I feel that we've made a lot of advances in medicine in general. But the conversation around death and dying, mortality, how to discuss it, how to think about one's own death is something that we need to get better at as a society. And I feel that if I have experiences from patient care that I can bring to the discourse, then it's helpful, I hope. When the average person thinks about health leadership, they probably don't think about leaders in the death and dying space. But I think that's really important because health leadership comes in all sorts of forms, from managing large organizations to leading a department to being advocates. I mean, all doctors are ultimately advocates for their patients, and so they should be. That's why society spends a lot of time and effort, and a place like Australia, money in training doctors. You know, my medical education was taxpayer funded. I feel an enormous responsibility to repay that debt to the public. So, you know, this is why I bring my experiences from patient care to the broader public, because every time I see a patient in some sort of a situation where it's relevant to other people, I think, well, what can we learn from this? How can we repeat the good aspects? How can we prevent the poorer aspects of this care to a broader public? So I think, you know, leadership in this space is as important as leadership in other spaces. Everybody wants to die well. Everybody wants to die without pain and suffering. I don't meet patients who say, I want my doctors to be dishonest, or I want my doctors to obscure information. And yet, because of the discourse we have around death and dying, no one is aiming to be dishonest, but a lot of conversations don't take place. It requires better training of health professionals, but also better acceptance from society that these conversations are important, and they can be uncomfortable and anxiety provoking. But a lot of times I see that when conversations about death and dying, and importantly, what to expect and what help we will provide patients, leads to a lowering of that anxiety and leads to better quality of life. And so that's really, in my view, that's where we need to get to. So I should preface this by saying that I have 3 wonderful, healthy children, but my very first experience of pregnancy was the loss of twins, which I've written about in the past. It's in sort of the public domain. I was more than halfway through a twin pregnancy. I was very fit and healthy. I was young. There was no indication that there was anything wrong, and we were in the United States at the time, came back to Australia. And when I went to meet my new set of doctors, they found that the twins were dying on the very first ultrasound, almost due to a fine print medical condition that I had never heard about. Very shortly after that ultrasound, within days, I had lost not one but both twins. I think that experience very early on in my career as a doctor really changed the way that I view these conversations about life and death. I think the obstetrician who was performing the ultrasound, given all the reports of my well-being, had not expected to find anything untoward. And I could tell from his face that something was wrong. He asked me to get dressed. He took me to his office, which was really not an office because generally women have ultrasounds and they go home. And he sat across from the desk and he began drawing a cartoon with red and blue demonstrating arteries and veins, trying to paint the picture of what was going on. And I just noticed how sad he looked. And behind him, there were pictures of his own children. And to this day, I think if he could have turned around and up and downturned all of them, he would have, because he was so saddened by what he had to say. And I remember I was alone in the room. I had gone for this routine test, and I said to the doctor, and I don't know what prompted me, I said, "Are the twins dying?" And being a doctor, I know that there were so many ways in which he could have answered that question. He could have dodged it, first of all. He could have said, we need more information, we need to talk to other doctors, so on and so forth, and really prolonged that fear and uncertainty at a time when I knew that something was wrong. And instead, he looked at me, his eyes were moist, and he said, yes. And while that was very dramatic and life-changing and horrible news to hear, in some way I felt, now I know. And now I can deal with what comes next, which was a series of appointments and procedures and so on. But I was just forever grateful to him for being honest in that moment. And I subsequently went and saw him with my healthy children, and we had some good conversations. But I think that experience really gave me a personal view of what it feels like to be on the other side, knowing that there's bad news and hoping that somebody will tell it to you in a gentle, compassionate manner and then take you to the next steps. And that's kind of how I think about end of life. You know, doctors like me are never in a position to say somebody is going to die at this time, on this day, and so on. But that's not what people are asking us either. What they're asking, I think, is to give them an idea of what life holds, what there is to look forward to, what are the things that they need to get done had they known that they have limited time. I think it's important to recognize that this advocacy matters. I'm very conscious to not talk unnecessarily about things and not have my voice in every aspect of conversations where it's not needed. But I think this is a space where it's very important for doctors and especially clinicians with experience to play a role in educating and empowering the public. And one of the principles, I suppose, that guides me is looking after people before they become our patients, and empowering them to have these discussions elsewhere at the dinner table, in their home, thinking for themselves, what does life look like? What does my mortality mean? How would I like the end phase of my life to be, rather than the very end of life? Because so much of this can be planned ahead. It helps people make different decisions about how they choose to spend their time. We know that with an aging population, we have a large burden of diseases that are not curable. They're manageable, but they're not curable. Everything from chronic lung disease to kidney failure to diabetes to bad heart disease to many forms of cancer, where we can help people remain well, but unfortunately those diseases are not curable. And I should mention dementia, of course, which is an increasing problem in society. So I constantly think, when people come to me to make healthcare choices, those really important decisions about whether or not to have treatment, whether to spend your time in a chemotherapy chair as opposed to home, the so-called time toxicity of treatment that I've written about as well. I think those things are really important. And unless we normalize those conversations, unless we make people feel that it's okay to think and to talk about, is treatment more important for this condition, or is time with family? Do I want to spend my remaining days going in and out of hospital, or should I go fishing? Should I go on that holiday? I think those are really important conversations, and we know that people are thinking about them in the back of their heads, but they don't feel that they are conversations they can have with their doctors. In general, the medical profession has always been charged, and historically been charged, with prolonging life, with curing suffering, curing illness. But I think now we have come to a phase where we are recognizing that a lot of what we can do is improve quality of life, but not necessarily banish illness. And I think we're catching up to that. And an important aspect of care as an oncologist is obviously using all the treatments and harnessing all the advances, the miraculous advances, in fact, in modern medicine, to help a patient, but not lose sight of the fact that death still happens, mortality is real and inevitable, and how to walk that tightrope between offering hope and nourishing that hope, but also being sensitive and real and authentic, that sometimes, despite our best efforts, in fact, it's not just the disease can't be cured, but the best thing for the patient is to have quality of life over more treatment. That is a really difficult discussion to have. And again, I think that is because we are constantly portraying, and especially in cancer, this notion that it's a war. And so, patient and doctor will team up to win this war against cancer. Our politicians use that terminology. The media uses that terminology. If you look at people who are celebrated in the media in terms of health professionals, it is often people who are curing something, people who have invented some brand new technology to do something else. Whereas I think we need to pay equal attention to people who don't have any shiny new technology to offer, but who offer good conversations. And palliative care doctors, for instance, good, wholesome conversations. They help guide people about what matters to them. And I think it is so important to inject the patient voice into whatever we are doing. And again, I think we are a long way away from that, and we need to do better. It's actually really hard for people, even people who make decisions in their best interest to say, I've had enough of ambulances and hospitals and emergency departments. they keep coming back. And I think, again, that is because as a society, we are so medicalized and we are over medicalized. And so all these people, despite their best wishes, despite their strong wishes to avoid hospitalization, end up there because we are not set up still to offer good supportive care in the community, to offer good palliative care. And one of the things that people fear is if they say they don't want anything, they will be abandoned. And so we need to change this paradigm where don't want anything has some meaning in terms of I don't want toxic treatments or I don't want to be stuck in hospital. But it doesn't mean these people don't want or deserve care. So we need to shift care to the community so people feel looked after and don't feel that the only way to receive care and medical input and nursing and social input is by going to the hospital. Because of course the hospital is one of the worst places for such people. It's noisy, it's fragmented, you are removed from the people who you love, who love you. In the time of the pandemic, it's been particularly difficult and remains difficult for people to be visited by their family members and relatives. We need to reimagine healthcare where people at the end stages of life can feel well supported and equally well looked after in their home. When Italy was in dire straits, one of the first countries where has a predominantly older population and people were dying and there was a lack of intensive care beds. And I thought that that was one of the first conversations that we needed to have, and I wrote about this because there was a lot of panic in the country about how we would run out of intensive care beds for patients. And then there was this fear about then how would we ration beds. And I thought, well, that's actually not the way to think about this. The way to think about this is who would benefit from intensive care and what does that involve? To the average individual, intensive care means literally intensive care. You get a lot more care. You have a nurse attached to you. It is the place to get better. But in fact, if you are so unwell that you go to intensive care, your chances of recovery are generally poor. And the more illness you have, the older you are, the sicker you are, the worse your chances of recovery. And even if you get out of intensive care, that's not the right metric because you may be left with a lot of disability. You may be left with cognitive fog, unable to return to the level of independence that you had before. And somehow all of that conversation went missing, and instead people became very angry to say, well, how come, my grandma won't get an intensive care bed? And that's kind of some form of discrimination. So that was one conversation that was really important to have and to bring into the public discourse about understanding when to say enough, when to say, that's actually not good and not in the best interest of my family member or me if I became so unwell. I think, I feel very sorry for all the people who were hospitalized during the pandemic. It was a terrible time when, there was a lot of fear, alarm, uncertainty, especially as things were evolving in the early days of the pandemic. People who died without their relatives at their bedside, stories of people trying to look through windows and appealing to hold the hand of their dying relative for the last time. And I had several patients like that where we tried as much as possible to connect people via FaceTime and video apps and so on, but it wasn't easy and it wasn't uniform and there was a tremendous amount of suffering. I hope that led to some reckoning in the broader profession, but also in the people who administer healthcare, that those rules designed to keep us safe actually caused a lot of trauma and lingering trauma. While many of us are moving on from the acute phase of the pandemic, there are many, many families and relatives who lost people who they won't get back, whether it was due to a chronic illness or due to COVID, etc. My patients are often in their 80s and 90s, so their children are in their 60s and 70s. And it's such a burden for the entire family unit to care for somebody in the hospital, especially when that person could be looked after in the community. I mean, let's get this straight. There are things that need to be done in the hospital, major surgeries and transplants and treatments. So I'm not saying everybody should get care in the community. But if we are talking about the end stages of life, the last part of life, where life is more about community, relief from pain and suffering and symptoms, as much time as possible spent within one's home, wherever that home is, whether it's residential care or your own home or somebody else you live with, having the freedom to have families go in and out as they please, all of that doesn't happen well in the hospital. And so if we had better community structures, and if we had palliative care, not only nurses, but the gamut of palliative care from social workers and doctors and troubleshooters and allied health, all of that provided in the community, I think it would be cheaper than admitting a patient to hospital. And more importantly, I think it would lead to dying well and better for many people. I will add a caveat to that. I think that we talk a lot about people wishing to die at home and wishing to die outside of hospital. But what we don't see, and what many patients will tell me, and relatives in particular, not so much patients, will tell me, I can't do this at home. And so we need to be very cognizant to not say all dying should occur at home because that's what all patients want and all relatives want. It's actually not true. And increasingly, we see a part of the population that is very elderly, very stretched for resources, not so confident. And so for them, what works best is actually support in an institution, in an institution that says, we will look after this person, but you can come and go as you please. Frankly speaking, looking after somebody who is very unwell or dying, looking after them at home with the few services we offer these patients is really hard work, both physically but also psychologically. And I think we have to make room for that. So when we talk about a movement of moving death and dying away from the hospital, we need to be very cognizant that we have to provide the right structure, the infrastructure, to make that possible. There is considerable evidence that doctors would not choose many of the treatments that they prescribe to their patients, whether it's chemotherapy at the end of life, whether it is languishing in the intensive care unit of a hospital, whether it's being in emergency under bright lights and noise, and not many relatives in a bustling emergency department. So I suppose that I would like for myself what I advocate for my patients, no more and no less. I hope that I grow old well. I hope that when my time comes to deal with illness, that my doctors and nurses harness every bit of medicine and technology available to them to help me. But I also hope that I find the sorts of doctors who are not afraid to have difficult conversations with me and who have the fortitude and the training to tell me when the chances of a treatment working are futile, when it would be better to not have treatment, not spend time in the hospital, and transition to something that is better for my quality of life, that helps me leave a meaningful legacy, and that helps me maximize my time at the end of life, because let's face it, it's going to happen to all of us. So, that may be a big wish list, and my aim for the next phase of my career is to ensure that my patients receive that sort of care, and that other people in the future do as well.